Welcome. We will start by exploring the concept of evidence-based practice. This is something that all healthcare professionals should be doing in every interaction with every patient, but unfortunately, sometimes it still does not occur. The importance of this class is to explore how to implement these strategies to improve our patient care, to advocate for our patients, to minimize our liability, and to even improve the public's perception of healthcare professionals. Providing the best possible patient care involves staying up to date on advances in the healthcare profession. That is why the Board of Certification for Athletic Trainers added a new continuing education category beginning in 2014. The Evidence-Based Practice, or EBP category, helps athletic trainers infuse the best new evidence into clinical decision-making with the goal of improving patient outcomes. By completing activities in the evidence-based practice category, individuals learn how to find and analyze the most current research evidence available. Then, with the research in hand, clinicians can use clinical expertise and their patients' own values to make healthcare decisions. To assure that athletic trainers and other healthcare professionals have the opportunity to learn about new healthcare research, the Board of Certification now requires a certain number of evidence-based practice continuing education units, or CEUs, to maintain certification. So what is this evidence-based practice concept? Let's dive in. Evidence-based practice should become a foundational behavior of professional practice. There are several reasons why we employ evidence-based practice with our patients. The first is the primacy of the patient. We use this approach to provide the best healthcare available for the client or patient. We want to advocate for the needs of the client or patient. As we continue to explore evidence-based practice, the patient is the most important factor to consider when choosing an appropriate treatment or intervention. Evidence-based practice allows individuals to use a team approach to practice and to provide clients and patients with care. This team approach places the patient in the driver's seat. We include the patient in the decision-making processes of their care and may even include their family when it is appropriate. We can also work effectively and efficiently with other healthcare professionals to affect positive patient outcomes. This approach allows us to advance our knowledge. We do this by critically examining the body of knowledge in athletic training and other related fields. We use evidence-based practice as a foundation for the delivery of care. This promotes the value of research and scholarship in healthcare. This also allows us to disseminate new knowledge in the field of athletic training or other healthcare professions to fellow clinicians, clients and patients, other healthcare professionals, and even to community stakeholders. Along with evidence-based practice, there are some foundational behaviors of professional practice that we need to touch on. One is cultural competence. This is the demonstration and awareness of the impact that the client or patient's cultural differences have on their attitudes and behaviors towards healthcare. Not everybody approaches healthcare the same. We need to be able to demonstrate knowledge, attitudes, behaviors, and skills that are necessary to achieve optimal healthcare outcomes for diverse patient populations. Understanding what is important to individual patients is the key to evidence-based practice. Another one is professionalism. We want to continue to advocate for our profession. We want to exhibit compassion and empathy and demonstrate effective interpersonal communication skills. Evidence-based practitioners incorporate the best available evidence, their clinical skills, and the needs of the patient to maximize patient outcomes. An understanding of evidence-based practice concepts and their applications are essential to sound clinical decision-making and the critical examination of athletic training and healthcare practices. So let's think about this. To put this into clinical practice, as we start talking about evidence-based practice, let's examine a simple question. Most of us have been injured at one point or another in our lifetime. So why do we always use ice right after an injury? Is there good evidence for it? What about other modalities? And why do we use ice the way we do? Why don't we use other modalities more? What were we taught, or what have we experienced versus the theory? This is sometimes called the theory versus practice conundrum. The first instinct of countless coaches, healthcare professionals, and even parents is to get a cold pack on an injury right away. Some studies say that this practice actually could be counterproductive in the long run. A study published in 2013 in the Journal of Strength and Conditioning Research reported topical cooling, icing, or cryotherapy seems not to improve, but rather delay recovery from eccentric exercise-induced muscle damage. So why do we use it? As we've stated, an understanding of evidence-based practice concepts and their application is essential to our sound clinical decision-making and critical examination of athletic training or healthcare practices. Practicing in an evidence-based manner should not be confused with conducting research. While conducting research is important to the profession of athletic training or other healthcare professions, developing the ability to conduct research is not an expectation of professional education. However, it is important for professional athletic trainers and other healthcare providers to use a systematic approach to ask and answer critically relevant questions that affect patient care by using review and applications of existing research evidence, such as our situation here with the ice. As we'll continue to examine things, sometimes what we've always done does not necessarily match up to what the research says in the literature. Evidence-based medicine and evidence-based practice are the terms that are used interchangeably. Other terms that may be used include evidence-based medicine, evidence-based practice, evidence-based clinical practice, evidence-based healthcare, and even evidence-based athletic training. Sackett was one of the first to define evidence-based practice, and he said that evidence-based practice and evidence-based healthcare are more In 1996, Dr. David Sackett defined evidence-based medicine as the conscientious, explicit, and judicious use of current best evidence to make decisions about the care of individual patients. Subsequently, Sackett and other researchers in 2000 redefined evidence-based medicine as an integration of the best available evidence, clinical expertise, and patient preferences and values. This simpler and current definition gives equal emphasis to the patient's situation, the patient's goals, values, and wishes, the best available research evidence, and the clinical expertise of the practitioner. Over the past 20 years, the practice of athletic training, while relatively new in the allied healthcare profession, is following this trend. The new critical thinking methodology has presented challenges to some individuals now. Most certified athletic trainers make decisions based on their experiences or do things because that is the way they've always been told to do them. Their decisions are rarely informed by research evidence. We want to make sure that we're incorporating new theories or evidence into our practices, because if we're used to the way things have always been done, it can ultimately impact patient health care. An evidence-based approach has emerged in response to the need to improve the quality of health care and to demonstrate the best use of limited resources. The forces driving the need to improve quality of care include variations in practice. This is a translation of the theory into practice, which is difficult. There are variations among practices or techniques that are well documented. Number 2, sometimes there is a slow transition and assimilation of scientific evidence into practice. Variations in the practice do occur due to a gap between the time current literature knowledge becomes available and its application to care. There is a delay in adopting useful procedures and discontinuing ineffective ones. Assimilating scientific evidence into practice requires that clinicians keep up to date by reading extensively, attending courses, and to take advantage of the internet and electronic databases to search for published scientific articles. Colleagues and personal journal collections tend to be the primary information source for treatment decisions rather than scientific literature. Treatment decisions tend to reflect the knowledge, skills, and attitudes of individuals learned as a student. Number 3, managing the information overload. It is physically impossible to keep up to date with the increasing number of published articles. The challenge is to find relevant clinical evidence when it is needed in order to help make well-informed decisions. Having access to online databases and computers can help clinicians to answer questions. And number 4, changing educational competencies. This requires students have had the skills for lifelong learning. Sackett, who defined evidence-based medicine, went on to argue that evidence-based medicine is not old hat or just the same old medical practice, as evidenced by the wide variation that occurs in clinical practice patterns. Neither is it intended to be cookbook medicine where every patient receives the exact same treatment. As evidence-based medicine specifically advocates for the individualized application of evidence to patient care, not forcing patient care to conform to generalized evidence. Evidence-based medicine is not intended primarily as a cost-saving tool. It is intended to guide practitioners to the best, but not necessarily the cheapest, care. Lastly, evidence-based medicine is not intended to only be concerned with randomized controlled trials, but also with the best relevant evidence applicable to the situation in question. So what evidence-based medicine is? It's tracking down the best external evidence with which to answer our clinical question. So let's think about this in a different way. If you were a patient who had an injury or who was ill, and you had to choose between two physicians, who would you choose? You have a wise and experienced physician, or you get the smart and young, maybe even newly trained physician. Who are you going to choose? Which one would you want, and why? I think if most of us had to pick at a spur of a moment, there are some benefits to having someone who's experienced. But there's also a possibility that that individual may not be trained in the most relevant and recent techniques. And then you have someone who is younger. They may be trained in the most recent technique and protocol, but they may not have the experiences to make the best decision. So, what to do? What to do? Well, what if we could combine these two? The concept of evidence-based practice attempts to do just that. Evidence-based practice provides an avenue to bridge the gap between published research and clinical practice. The idea is we want to create a culture of lifelong learners. This is Sir William Osler. He was born on July 12th in Bond Head, Ontario, Canada. He was a Canadian physician and one of the 4 founding professors of Johns Hopkins Hospital. Osler created the first residency program for specialty training of physicians, and he was the first to bring medical students out of the lecture hall for bedside clinical training. He has frequently been described as the father of modern medicine and one of the greatest diagnosticians ever to wield a stethoscope. Perhaps Osler's greatest influence on medicine was to insist that students learn from seeing and talking to patients and the establishment of the medical residency. Sir Osler wrote an essay in the Books of Men that he who studies medicine without books sails an uncharted sea, but he who studies medicine without patients does not go to sea at all. His best known saying was, "Listen to your patient. He is telling you the diagnosis," which emphasizes the importance of taking a good history. Another one of his famous quotes was, "The hardest conviction to get into the mind of a beginner is that the education upon which he is engaged is not a medical course, but a life course for which the work of a few years under teachers is but a preparation." If we think about the time in which Sir Osler said these things, not much has changed in allied healthcare or the medical field. The idea of educational programs is to create lifelong learning and set students up with a system to understand how to continue to advocate for their patients and to find the best available evidence to be able to give them the best healthcare possible. Physicians with more experience are generally believed to have accumulated knowledge and skills during their years in practice, and therefore should, in theory, deliver higher quality of care. Unfortunately, from the available research, career longevity does not necessarily equate to better quality of health care. Evidence suggests that there is an inverse relationship between the number of years that a physician has been in practice and the quality of care that physician provides. Physicians who have been in practice longer may be at risk for providing lower quality of care. Therefore, this subgroup of physicians may need quality improvement interventions. It also raises concerns about the adequacy and effectiveness of continuing professional education in healthcare and medicine. Unfortunately, research like this does not only exist for physicians. We see this commonly in other healthcare professions as well. So one of the ways that we can combat and hopefully improve patient outcomes is by incorporating evidence-based decision-making and practices into the training of healthcare providers. Evidence-based practice is a systematic method of reviewing the best evidence, combining it with the art of athletic training or your clinical expertise, and making informed choices to treat the patient. Evidence-based practice is focusing on the patient and their clinical outcomes. Clinical expertise includes the clinician's cumulative experience, education and clinical experience, and clinical skills. This includes your own personal values, preferences, experiences, and wisdom. Clinical experience develops over time from observation, trial and error, and results in feelings of accomplishment and pride. Our patient values. The patient brings to the encounter their own personal unique concerns, expectations, and values. Patient values are the preconceived ideas and beliefs that each individual brings to the clinical setting. Each individual has their own concerns and priorities that the clinician must address. The best research evidence is usually found in clinically relevant research that has been conducted using sound methodology. This is a scientific and systematic process generating evidence through hypothesis testing and sound methodology. This is maybe the most challenging portion of the evidence-based practice concept to complete and incorporate. For many, understanding and interpreting research articles can appear daunting and overwhelming. Published studies should introduce a research question, describe the methods used to assess subjects, outline the variables of interest, and explain the participant inclusion and exclusion criteria. The statistical analysis should align with the research methodology, and the author should only report facts in the results section. An individual must assess the quality of the clinical research article prior to using it. An important rule in evidence-based medicine. It starts with the patient and it ends with the patient. The patient's preferences must be considered. This is a continuous process during the entire interaction and any subsequent interactions with the clinician and the patient. There are 5 steps in evidence-based practice, or some people like to call them the 5 A's of EBP. Number 1, create a clinically relevant and searchable question concerning your athlete. Number 2, conduct a database search to find the best available evidence. Number 3, critically appraise the articles or evidence located for quality. Number 4, critically synthesize the evidence to choose and implement a treatment. And then number 5, assess the outcomes by monitoring the athlete. Well-built clinical questions should be directly relevant to the care of the patient in our knowledge deficit. They also should contain some specific elements. Evidence alone is never sufficient to make a clinical decision. Initially, the focus of evidence-based medicine emphasized the use of randomized clinical trials and other quantifiable methods. However, evidence-based medicine has evolved. So has the realization that the evidence from clinical research is only one key component of the decision-making process and does not necessarily tell a practitioner what to do. A hierarchy of evidence exists to guide clinical decision-making. Evidence-based decision-making is a structured process which incorporates a formal set of rules for interpreting the results of clinical research and places a lower value on authority or custom. In contrast to evidence-based decision-making, traditional decision-making relies more on intuition, unsystematic clinical experiences, and pathophysiological rationale. Despite many clinicians having a positive attitude, knowledge, and the skill to implement evidence-based practice, many clinicians and allied healthcare professionals, including physical therapists, occupational therapists, speech pathologists, dietitians, and social workers, among others, rarely practice tasks associated with evidence-based practice, according to the literature. The ideal evidence-based practitioner will critically reflect on their practice on a regular basis, asking whether or not there is a better way to do things. This clinician will then answer the questions generated by this process of critical reflection using relevant, valid information rather than anecdote or opinion whenever possible. Finally, answers to questions that change the clinician's practice should be implemented. Unfortunately, there are many potential barriers to this ideal model of reflective evidence-based practice. The first step in the information pathway is to recognize that information is needed. The willingness to recognize that one's knowledge might not be complete would appear to be driven primarily by individual attitude and personality. Work by educators in the area of critical reflection suggests that this skill is mature and high-level thinking, but that it might be undermined by an emphasis on what is single-loop learning versus double-loop learning. Consider the example of a patient who has a cough, which is diagnosed as bronchitis and who is given a specific antibiotic. When the patient returns 2 days later with persisting symptoms, the physician may just change the antibiotic. This behavior is considered single-loop learning because the physician reacts to the situation without questioning the underlying assumption. A more reflective physician would practice double-loop learning. When the patient returns, both the underlying diagnosis and the treatment strategy should both be questioned. Maybe the patient doesn't actually have bronchitis. Perhaps the patient has acid reflux or even allergies. What if the bronchitis is viral and the antibiotic is not going to help anyway? Have they even considered if the antibiotic that they prescribed helps, even if the bronchitis is bacterial? The reflective physician, even in this simple clinical situation, should generate a host of important questions. In addition to generating more clinical questions, the reflective clinician is more likely to practice patient-centered medicine, tailoring the management strategy to the patient's clinical picture, needs, and situation. For example, taking a one-size-fits-all approach to the management of a sore throat by ordering a rapid antigen test for everyone who has a sore throat provides too much care for some and not enough for others. By reflecting on our practice and asking whether a rapid antigen test is needed for a particular patient, care is then individualized and outcomes are perhaps improved. The decision to pursue a clinical question is the most complex step in the information pathway. This is influenced by a physician's attitude, personality, and work ethic, the characteristic of the question, and the practice environment. Previous research has shown that decisions to pursue a clinical question is driven most strongly by the importance of the question and the perceived ability of an answer to the question. The former might vary depending upon the physician characteristics such as conscientiousness, work ethic, and a sense of duty to the practice. The perceived ability of an answered question depends in part on the physician's knowledge of the available resources. The ability to satisfy an information need and to answer a clinical question, once the physician decides to pursue it, is determined by the knowledge available resources, skill at framing a question, and searching of those resources, and the context or the environment. Physicians tend to frame questions in relation to specific patients rather than in a generalized fashion, as is advocated by teachers of evidence-based medicine. Environmental factors, such as access to informational sources and the time available between patients, will affect the decision to pursue a clinical question. The environment, setting, or context also influences a physician's ability to answer a clinical question in terms of both time and availability of resources. Finally, the decision to implement the answer to a clinical question in practice will depend on such environmental factors such as cost, healthcare system constraints, patient acceptance, acceptance of colleagues, and local practice patterns. The amount of work needed to implement a change as well as the importance of the question are both important. While I realize this information pathway example was for physicians, I think it could be equally applied to other healthcare professions as well. Clearly, asking and answering questions is central to the practice of evidence-based medicine and information mastery. During this course, we will learn about clinical questions, how to ask better ones, and how to answer them with the primary and secondary medical literature. This expertise will be very valuable whether you are involved in direct patient care, policymaking, or even public health practices. Direct observation studies have shown that primary care physicians generate approximately 10 to 15 questions per day of practice. As you continue your clinical experience, either as a student or as a young professional, I'm sure you're going to have many clinical questions as well. One of the biggest barriers that individuals face is information overload. How do we get the output that we want? This is one of the things that we will discuss further and further as we delve into evidence-based practice during this class. So keeping up, is it mission impossible? No, it doesn't have to be. With the proper knowledge, equipment, and practice, we can navigate the system, which makes implementing evidence-based practice so much easier. We'll continue to learn as we progress through this course.